Good afternoon and good evening, everyone. I am Sudiksha from Shalina Healthcare. I welcome you all for this live discussion on hypertension. Every year we celebrate May Measurement Month and World Hypertension Day on 17th of May. Because of the alarming rise in hypertension prevalence across the globe. Just take a look at the prevalence data. It's really a time for an action. We can see here people with hypertension living in Africa. It has rise almost 100% in next 30 years. So from 92.3 million in 2000 to it is going to rise to 216.8 million to in 2030. So there is a very high risk of hypertension related comorbidities in people of Africa. Simultaneously, as we know the prevalence of hypertension is high, it is very important to measure blood pressure accurately. So there is just a small statistical data which shows that inaccurate BP measurement is persistent and pervasive problem not only in Africa, across the globe. And if you can see that just the difference of 5 mm of Hg in BP measurement can incorrectly classify hypertension status in 84 million individuals worldwide. So that's why every year this May Measurement Month and World Hypertension Day is celebrated to know the importance of accurate blood pressure measurement and to create awareness on measuring the blood pressure. So in view of this, we are coming up with this live discussion on hypertension from accurate blood pressure measurement to early morning blood pressure surge management. Since early morning blood pressure surge is one of the important risk factor for the cardiovascular event, as majority of the heart attacks and the cardiovascular event are experienced in the early morning hours. So this webinar is brought to you by Shalina Academy, an educational initiative from Shalina Healthcare. So before we start this live discussion, just a small brief on Shalina Healthcare. So we are a Africa specific company. We have been operating in Africa from last 40 years and we are one of the largest pharmaceutical companies in sub-Saharan Africa. Our major mission is to provide quality medicine at affordable price and to make it readily available, which we manage through our own distribution channel. We maintain our quality product by manufacturing them in WHO approved facility. Besides this, besides selling the products, we are also aware about the social responsibility. In view of this, we conduct a lot of social responsibility campaign, deworming camp, and the educational initiative like this live discussion. So, as we know, we are observing May Measurement Month and the World Hypertension Day for on 17th of May. So, to have this live discussion, we have a very experienced and the eminent speaker from India and Africa. Let me introduce Dr. Jamshed Dalal, sir. Sir is a rare triple doctorate. Sir has done doctorate in medicine, doctorate in cardiology, and PhD in cardiology from UK. Sir is a director of cardiac sciences, Kokilaben Hospital, Mumbai. Sir is a life member of Cardiology Society of India and a fellow of European Society of Cardiology and Royal College of Physicians, London. Sir is also a member of Indian College of Intervention Cardiology. Sir did his first angiography in UK in 1978, and since then he has done more than 20,000 cases over these years. Sir is also a course director and speaker at hundreds of cardiology conferences over the past 30 years. Sir is also a recipient of Young Research Worker Award by British Cardiac Society in 1981 and also a recipient of JC Award, the Outstanding Young Person in 1985. Besides this, Sir has immensely contributed in the scientific world by publishing more than 35 articles in peer-reviewed journals. Let me introduce our another speaker, Professor Familoni. Sir has done his MBBS and MD from Nigeria. Sir is a professor of cardiology, Department of Medicine from at Onabanjo University Teaching Hospital, Nigeria. Apart from this, Sir is a member of various editorial boards of various journals, cardiovascular like Cardiovascular Journal of Africa, Nigerian Journal of Cardiology, expert panel in reviewing the guidelines for the management of hypertension in Nigeria. Sir is also a life member of World Heart Failure Society, American Heart Association, European Society of Cardiology, Nigerian Hypertension Society, Nigerian Cardiac Society, and Nigerian Medical Association. Sir is also a fellow of American College of Cardiology, Medical College of Physicians. Apart from this, Sir is a recipient of National Award University Scholar for 1973 to 78. Sir is also actively contributing in investigator-initiated studies and also a part of a registry for acute coronary event in Nigeria. Besides this, Sir has authored 2 books and presented technical paper in several conferences. Coming to professional achievements, Sir has published 63 publications in peer-reviewed journals. Welcome, Sir.
Thank you.
I will just give a brief of this live discussion. So, speaker introduction is done by me, so it is already done. Then I will be handing over session to Professor Familoni for the giving the brief scenario on Africa. Later on, which will be followed by the question answer discussion between Professor Familoni and Dr. Dalal sir. And lastly, we will have the audience question. So thank you everyone. I hope you will enjoy all this discussion which is going to happen in next 1 hour. Over to you, sir. Over to Professor Familoni, sir.
Thank you very much. Good day, everybody, to this important webinar. I want to welcome you to the World Hypertension Day. We'll be looking at accurate blood pressure measurement and early morning beep salt management. What I intend to do is just give an overview in the next 10-15 minutes, and myself and Professor Jali then will go on and look at specific questions that might arise. Can I see my first slide, please? Okay. This is WHO statements in the last 2 months that gives an overview of the extent of the problem of hypertension all over the world. About 1.28 billion people are said to be hypertensive. Again, it's because we put the cutoff point at 79. If you put cutoff up at 85, as we know that blood pressure increases with age, right? We'll have much more than this. And then it's a projection. That's, if we not very careful, we have up to 2 billion in a few years' time. But the more important thing really is that most of these people, about 2/3, live in low and middle income countries, of which we are in sub-Saharan Africa. So it's a major sub-Saharan African problem. It's interesting. It used to be said that hypertension is a problem of the Western world, but epidemiology has shown that more and more it is more of the developing world. The not too good news is that almost half of the people who are hypertensive do not know, and that's why we call it a silent killer. People are moving around with various blood pressures, even sometimes we say 3 hypertension, 180, 100, and they don't feel anything. And I used to say, I would tell my students that in hypertension, the first symptom might even be the last symptom. The first symptom might just be that the guy has a major stroke or a major heart attack. And so that is one of the issues with hypertension. It's a silent killer. People are not aware, they're moving around. And unfortunately, even those who are aware, only about half get any form of treatment at all. And we talk about the rule of half. Okay, with the rule of half, that is, half of the nation population are not aware, half of the population that are aware are not being treated. And we used to say that half of the population that get treated are not treated to target control. But we now know that it's only about 20% of people who are being treated that get under control. And there are various reasons for this. And it's not just in Africa or in developing countries. It's all over the world. In fact, in best centers in the world, what you have are just about 25%. I guess in Africa, if we take an average, it will be less than 15%. Like I've said, hypertension is a major cause of premature death worldwide. In fact, hypertension and cardiovascular diseases cause much more death than many cancers, many HIV and things like that. So it's a major problem. And it's, of course, the greatest non-communicable disease in the world, second only to smoking in sub-Saharan Africa, okay? And that's why WHO is trying to make sure that we'll get this as low as possible. The last is that the number of adults with hypertension increased from 594 million in 1975 to 1.13 billion in 2015. And like I said, it's projected that if things are not done very well by 2030, about 2 billion people will be hypertensive. Again, the bad news is that majority of this increase occurs in the low and middle income countries. Next slide, please. Next slide shows. Next slide, please. Okay, next slide is just a composite thing of what is happening in sub-Saharan Africa. Because of time, I've just decided to take this meta-analysis, a systematic review from an author in Ghana about 3-4 years ago. And you can see the prevalence of hypertension. It ranges from about 22.3% to 90% from individuals. And if you put them together, you see more than half of the continent's population is hypertensive, and that is terrible. That means 1 out of every 2 people who are walking around have elevated blood pressure. And like we said, half of those people are not even aware at all. And we'll be showing slides later to show that most of this problem occur in Southern Africa. If you look at older slides, talk about Sudan and the Horn of Africa having the highest prevalence. Also that slides. But now we know that Southern African, particularly the Black Southern African, perhaps have the highest prevalence of hypertension. Like I said earlier on, it increases with age. And the older you are, because of atherosclerosis, because of non-responsible things, because of that, your blood pressure will keep increasing with age, okay? And so the older you are, the more likely the prevalence. The prevalence of hypertension in the younger group is low about 53%, but in the older age, will go about 61%. Again, we'll be showing slides to show that most of the problems occurs in the what we call the WHO African region. We have the highest prevalence of hypertension, which is about 27%, and compare with some other countries, other WHO African regions, that's only about 15%. Next slide, please. The next slide shows problems of blood pressure measurements. And this is important. There was a paper that came out of South Africa about 5-6 years ago that surveyed general practitioners, doctors, and found that only about 26% of doctors in general practice measure blood pressure actively. And these are some of the factors that affect blood pressure. And blood pressure measurement has to be accurate, because it has been shown that even a difference of 2 millimeters of mercury is only blood pressure, have a lot of changes, has a lot of consequences, in particularly in stroke and myocardial infarction. And so if you have problems that you say, oh, it's just only 2 millimeters of mercury, either a rise or a decrease in 2 millimeters of mercury shows a lot. These are some of the problems. The setting where the attention, where the blood pressure is being measured, whether in the office, whether at work, whether at home, in clinic or ambulatory. We know, of course, that office or clinic measurement in some people are higher, and that's what we call the white coat effect. Or they can even call the white coat hypertension, white coat effect, in which we know that this guy is hypertensive. but the blood pressure is always higher when it comes to clinic. And when they measure it at home, it's always lower. And now this is called the white coat effect. White coat hypertension, for example, a person is not hypertensive at all, but because he comes to hospital and is afraid, we'll see the white coat, the blood pressure goes up. And when he gets home, blood pressure is normal. And that is why we use ambulatory blood pressure, which we'll talk about, that shows what happens at home, at work, and other things. The time of the day in which you also measure the blood pressure is very important. I'm going to be talking about when we talk about the circadian pressure. Okay, people believe that blood pressure should be lowest when they wake up in the morning, and that is really not true. Of course, again, we'll be explaining this because of the circadian release of sympathetic activity, including noradrenaline and adrenaline, which is highest early in the morning. Okay, and there are about deepers and non-deepers. We know that blood pressure usually is lowest around 2 a.m. Till about 4 a.m., 5 a.m., and then begins to climb. So when you measure the blood pressure, depends again on what the result you get. And this way, again, ambulatory blood pressure monitoring is important. Observer error, I've just mentioned one. Approximation. Oh, people are measuring with fig. The mercury fig has in 2 millimeters gaps, and people who approximate instead of 124/84, it is 125/85. And I keep asking people, where do you see 5 in these things? Again, it depends who is measuring it, whether it's a nurse, a technician, automated devices. And that's what take us to devices. The mercury sphygmomanometer is being phased out because of the problems of spilled mercury and the health hazards, but it's still the standard. It's still the standard. Many of you use the digital, and I know that if you take your blood pressure 3 times with some of the digital devices, you get 3 different figures. Okay, and there are even conditions like people with atrial fibrillation, for example, in which you will not be able to get any result from the digital. And so it depends on what device you are using. And we advise, like we'll be talking about later, we advise that even if you are using an Android or any of the digitals, occasionally, once in 3 months, check with a mercury. Posture is very important. We wrote a paper in Cardiovascular Journal of South Africa a few years ago, in which we looked at the position and the arm position and found out that when you hang your arm by your side, or when you raise it up, or when you support it, the blood pressure are always very, very different. Okay, and so the position of the patient or the client, or whether the guy is lying down or seated or standing, is important. Of course, we know about postural hypotension. Some people blood pressure lying down or sitting down is okay, but when they stand up, it drops really badly. And these are the issues that are important in measurement. I've talked also about first reading. Okay, ideally, the first visit you should use both arms and then use the other arm. People who are coming to hospital for the first time, they are apprehensive. There's fear, and blood pressure tends to go up. And many times we ask them to come back in 24, 48 hours. I've talked about calculation, averaging blood pressure. A patient has 138/94, you put it at 140/95. And these are the problems, okay? Of course, there is a BP variability and reactivity, which are the factors that affect blood pressure. And so the next slide, how should blood pressure be ideally measured? Next slide, please. Okay. The ideal way to measure blood pressure is first of all, you need to standardize these issues on the upper panel. You need a quiet, comfortable room with comfortable temperature. We know that too much cold can cause vasoconstriction and allow your systolic blood pressure to go up. Okay, and so you need a quiet room, not too warm, not too hot. If it's too warm, there is vasodilatation. If it's the blood pressure might be low. If it's too cold, there's vasoconstriction. Blood pressure might be too high. Ideally, 30 minutes before coming, the patient must not have smoked. I must not have taken coffee. We know that all this causes endothelial dysfunction and increase sympathetic output and raise the blood pressure. Empty bladder is important, particularly in men, because the pain that comes from a full bladder raises systolic blood pressure, and so usually the patient should have emptied his bladder. He should have been sitting down quietly, relaxing, ideally for about 30 minutes. If you can't do it, at least 3 to 5 minutes. And you should take measurements about 3 times, about 2 minutes apart, and then take an average. And having satisfied those conditions, most studies have done that patients are sitting down, and so the patient should sit down. If the patient cannot sit down, patient should lie down. It's important that your feet must be on the ground and your back is well relaxed. Ideal cuff depending on the bicep circumference. If you use too tight a cuff, you're going to have an elevated blood pressure. No talking, and arm resting at heart level, okay? And you do this, and you validated it, and then you get your blood pressure. Blood pressure measurement is not a thing that you worry about. It's systematic, intentional, and usually takes some time to get a good result. Next slide, please. Next slide shows one of the things about circadian rhythm that we'll talk about. BP, blood pressure is lowest during sleep, usually about 2 a.m. and begin to rise. And that's why people usually have events early in the morning. Early morning surge is part of the circadian rhythm. It's a phenomenon that has an independent risk for cardiovascular events, particularly stroke, particularly myocardial infarction. Many of you would have observed that most strokes happen early in the morning. Patients cannot wake up. Patient then has one leg or one leg, and this is because the blood pressure tends to rise up from about 4 a.m. till about 10 a.m., 11 a.m. There is nocturnal dip, the deeper and the non-deeper, which is also important. If you are a non-deeper, you even have more risk of cardiovascular events than a deeper. And so drugs are important. You need drugs that will act for 24 hours, that is, that will act even during the time that the blood pressure is coming up. And you will need drugs that will control whether you're a deeper or non-deeper. And studies have shown that the RAS blockers, either ARB or ACE inhibitors, or a calcium channel with diuretics, which is recommended for blacks, is very useful. Last slide, please. Next slide. Okay, so this is my last slide before we go into discussion. There's a paradox of hypertension. It's such a common disease, but so easy to diagnose. All you need is just check blood pressure, check it properly. But unfortunately, it remains undetected in half of the population. It's so simple to treat. We have a armamentarium of drugs that you can choose from, and you can individualize and standardize. But despite all these potent drugs, treatment is often ineffective. Thank you very much. We will now go to discussion, questions, and answers. Thank you very much. All right. Dr. Daya, you are welcome to the discussion. We've given a background to the story. Can you have the first slide, please? Okay, but let's tell our audience why this yearly emphasized, particularly by the Hypertension League, on blood pressure. Why do we have to do this again and again? Dr. Dalal, please.
Thank you very much, Professor Familoni. I think you covered up a very large aspect of the importance of blood pressure measurement and how we are supposed to measure blood pressure. And I think that's extremely important. And again, we'll emphasize when we speak. Can I have the next slide, please? So first of all, there's a very practical definition of hypertension. And hypertension is basically a level of blood pressure at which investigation and treatment do more good than harm. I mean, clearly, if you have a blood pressure of 110/80, you're not going to treat it because that will do more harm than good. So that's a very simple, practical definition of hypertension. And as we look at the world guidelines at what level of blood pressure we should treat and what should be the target of blood pressure, it becomes very apparent that this is a very good definition of hypertension. Next slide, please. Next, please. Now, hypertension again never comes alone. So when professor asked why we should measure it regularly, because blood pressure is not a one-off diagnosis. It's not like you once diagnose a blood pressure, forget about it and treat for the rest of the life. because blood pressure will fluctuate. Different people will respond differently to medications, and blood pressure and hypertension never comes alone. It comes along with atherosclerosis, which can then produce coronary artery disease, eventually leading to heart failure. It can produce stroke, and of course, as you very well know, it can produce kidney damage as well. So really, hypertension needs to be monitored, not just for the blood pressure values alone, but we should also look at the multi-organ problems that blood pressure is associated with. So you need to look at the blood pressure regularly, and you got to see the effects of the blood pressure on various organs like the kidney, the heart, and the brain. Next slide, please. And again, why should we measure it? How often should we measure it? At least in the Indian context, we found that the hypertension incidence in India is around 25%. So again, like in Africa, the incidence is extremely high. It is seen both in rural and in the urban population. And again, like in Africa and rest of the world, majority of patients are not diagnosed properly. Now we know that a large number of patients have hypertension and are never aware of hypertension. So, and some of our guidelines, we have a feeling that the correct time to monitor the blood pressure at the first instance is at the age of 18 years. Now, of course, there is no big scientific study to show whether it should be 15, 18, or 20, but this seems an appropriate time at which to do the first measurement in the total population of your country. So everybody, wherever they stay, urban, rural, whether they know their blood pressure or not, should at the age of 18 years have a blood pressure check. Number one, it will help to pick up people who are hypertensive or pre-hypertensives, and it could pick up people who don't know their high blood pressure, but they are hypertensive. So you look on the left-hand side corner, we know the optimal blood pressure is 120/80 at that age. And if the blood pressure at that 18 years of age is 120/80, you don't need to measure it very often. You can do it after 5 years, because this is, we are talking of the full population study. Then if the BP at that stage, say at the age of 18 or 20 years, when you've done the first measurement, is 120 to 130, then of course you need to be a little bit more careful and probably measure more frequently at every 2 to 3 years. And if the blood pressure is already at 130/140, then of course you need to consider whether the person has masked hypertension, and therefore you need to do out of office BP measurement and then do blood pressure measurements more often, maybe every year. So this is for total blood pressure, total population, and you want to pick up as many blood pressures as possible, because we know that large number of patients, as Professor mentioned, in Africa are not aware their blood pressure. So therefore, it's important for the government to have a scheme where everybody's blood pressure is measured at least from the age of 18 onwards. Then, of course, if you have blood pressure which is more than 140/90, you need regular blood pressure monitoring. It may be every week, every month, every 6 months, or every year, depending on the degree of blood pressure, whether the patient's on only lifestyle modification or on therapy, and of course, how the patient responds to therapy. Next slide, please. So I think
All
that
right,
covers
thank
the
you.
first part of the questions.
Thank you very much. We've looked at the global issue that's a really big problem in the whole world. But can we talk about the global prevalence of hypertension and the factors driving increase in the prevalence? We have seen from your slide and from what I said that unless we do something, this prevalence will keep increasing. What are the factors driving this increase in prevalence?
Thank you. Next slide, please. So, Professor has already mentioned the global hypertension. And again, just to reiterate, there's millions of people worldwide who have hypertension, and almost 12% of the total deaths are related to high blood pressure. So clearly, as Professor Famolini said, blood pressure is a very, very big problem all over the world. Next slide, please. And we also know, and I think he also mentioned these factors quite again, but I think we need to re-emphasize, and estimated 46% of adults have hypertension, who have hypertension are unaware of it, which is why I showed the previous slide that it is, I think, the government's responsibility to make sure that everybody's blood pressure is monitored at an early age so that we don't miss it out. And of course, measure it at regular intervals, as I said, every 3 years or 5 years, to make sure that if the patient develops hypertension, then we pick it up again. Again, we know very well that hypertension is a major cause of premature death worldwide. And we've seen all these global targets, which of course hypertension is going to go up and up and up, and maybe reach about 30 to 35%. Next slide, please. Professor has already mentioned about this, so I don't want to go into details again. Again, shows that whichever part of the world you live in, whether it's Africa or India, the incidence of blood pressure is high. And as you can see from here as well, that it's not just an urban problem, it's an equally important rural problem as well. So please don't feel that it's only the urban population of high blood pressure. It is throughout the world and throughout all regions of the world. Next slide, please. And again, if you look at the major determinants, as Professor asked, there are, of course, the environmental problems like unhealthy diet, too much sodium intake, which is a very big problem in some of the South Asian countries, very poor potassium intake, poor physical activities with a lot of overweight and obesity. So these are important factors. Then, of course, we have genetic factors over which we have much less control. Both parents have blood pressure. Chances of you having blood pressure are very high. Multiple, gene-related factors. So that's something which we cannot, take into, cannot alter. And then, of course, there are social determinants like wealth, income, education, occupation. And I think this is important, particularly education and where you come from, because we know that many times patients who know they have blood pressure, they know they need to be treated, but they cannot afford to be treated. Or people don't have enough education. They know they have high blood pressure, but they don't realize the importance. I know so many people, even educated people, who we tell that they have blood pressure, but they don't think it's important enough to take treatment, especially the young people. 40-year-old person or 30-year-old person with a blood pressure 150 systolic, it's very difficult to convince them to take medicines. They feel that, oh, it's nothing to worry about. Similarly, if you look at the elderly, there's a general feeling that if you get old, it's okay to have high blood pressure. And we know very well that elderly controlling of blood pressure also is important. So I think we need to look at adherence to treatment. And for that, we require education and healthcare access. Because if you don't have healthcare access, then obviously your blood pressure is not going to control. So there are multiple genetic, environmental, and other social determinants of blood pressure problems. Next slide, please. And again, this has been mentioned again and again. If you look at the awareness, look at the treatment, and look at the control, both in the urban and rural population, and you can see nothing is over 50%. And that's shocking. Awareness less than 50%, treatment less than 40%, and actual control of blood pressure just at around 20%. So clearly, there's a lot more we need to do in terms of education, awareness, treatment, and control. Next slide.
All right. Thank you, Dr. Dali. It's mentioning very many important things. Okay, there are modifiable and non-modifiable things. You cannot do anything by your genetics. You cannot do anything if you have a family history. But it's mentioned important things, particularly about the environmental. In Africa, Saharan Africa, one of the problems that we've seen is urban migration. People move from rural areas, and all the issues associated with rural-urban migration, including diet, physical inactivity, and all those things. And these are the things that we can do something about. So we can do something about smoking. You can do something about exercise. You can do something about obesity. Okay, if at all you cannot even do anything about who is your father or from what tribe you come from. But having said that, it's still important to be able to measure blood pressure accurately, because that's how to make a diagnosis. And can you just tell us some of the reasons, some of the issues about accurate blood pressure measurements?
Next, please, slide. I think it's important to have blood pressure accurately measured. And I think Professor Familini already very well showed, and I have probably the same slide which he has shown, of how important it is when you measure the blood pressure to measure it accurately. Because we know that every few millimeters change of blood pressure can have a dramatic long-term effect in terms of your cardiovascular events. So it's important that we should have a clear picture of your risk of heart disease and stroke. You should avoid inappropriate treatment and use appropriate antihypertensive medication, and avoid the psychological effects of misdiagnosis. So you have a patient who comes running into your clinic and you measure the blood pressure and it's high, and you don't really think too much about it, start the patient on treatment, and the patient goes away with a permanent diagnosis of hypertension, which is why Professor mentioned again and again about the technique of measuring blood pressure. And I'll show the same slide again. Next slide, please. Now, again, this is a slide which shows the importance of the accurate measurement of blood pressure. So if you look at the top graph, it is cardiovascular disease. If you look at bottom graph, it is the mortality. And you can see how small variations of blood pressure produce a dramatic deterioration in terms of cardiovascular effects and mortality. So it's not that you require big 20 millimeter differences of blood pressure to get cardiovascular events or cerebrovascular events. You need only small changes of blood pressure in order to get them or to prevent them. So I think it's important to remember that if you want to monitor blood pressure, every few millimeters also counts. So therefore, you have to measure blood pressure accurately. If you do not measure blood pressure accurately, how are you going to actually predict the future prognosis, and how are you going to treat the patient? So it's extremely important to measure blood pressure accurately. Next slide, please.
All right, thank you very much. I'm sure our audience are interested about the common errors. You've mentioned some. What is your experience? What are the common errors in measurement of blood pressure, Dr. Dai?
Next slide, please. Now, again, I think professors already mentioned that. First of all, you have to be careful. There can be disease, devices related, patient related, and of course, the actual procedure of blood pressure measurement. So, device related, don't have a good BP machine. Now, we know that BP machines, there are so many different types of BP machines. Mercury machines are now banned. Most of the countries don't have mercury machines. You have oscillometer, the electronics, so many things, poorly calibrated machines. So, it's important for anybody who monitors blood pressure to take the responsibility that the device is correct. Here we are talking about every few millimeters being important, and if you have a device which is not important and not accurate, then of course, how are you going to get an accurate measurement? Then of course, the patient related. Patients on taken alcohol, caffeine, has come to you after smoking outside and then come to your chambers. His bladder is distended, he's like uncomfortable, or the temperature is too cold or too hot, he's just had a heavy meal. And of course, don't forget the white coat syndrome, which we all know very well about. And I think patient-related are very important because we never really bother. I mean, we all know how our clinics run. We are busy, patient comes running, patient's already distressed, something has happened to him. Then he comes to our clinic and we rush. We don't really give them time. So I think blood pressure should be monitored peacefully outside the doctor's chambers, maybe by a nurse who will be much less likely to produce a white coat syndrome. And then it's important to make sure the patient's body position is correct, make the patient rest, make sure the cuff size is appropriate. And this is particularly true for obese people, because if you have a big arm and you take the same regular cuff, you're going to overread the blood pressure. Again, as you know very well, placing the cuff over the clothing is again not the correct way, or talking to the patient or patient corresponding with you while the blood pressure is being taken. There's a very nice study which was presented in Lancet maybe a decade ago, where they quietly monitored blood pressure recordings of doctors in a clinic. And they were horrified to see how badly doctors monitored blood pressure. They were measuring blood pressure without making the patient sit comfortably, not explaining anything, measuring over the clothes inappropriately, doing the blood pressure, just doing one single reading and saying patient's got blood pressure. So clearly, I think that fault clearly lies with us doctors and the healthcare workers who take the blood pressure. So it's for us to make sure that all these are closely followed. Next slide, please. And of course, we know that we should have the BP machine validated. I think that's very important. Again, before you label somebody as hypertensive, please monitor blood pressure a number of times. I think nobody should be put on treatment for a single reading. Of course, if the patient comes to your clinic and has a severe headache and the blood pressure is 200, that's a different matter. Even in such a situation, I would make the patient wait outside, sit down, lie down, take the blood pressure again, give him another 15-20 minutes, check again. And then only if the blood pressure is high, I would say, yes, you require treatment. So just because the blood pressure is 150 when the patient rushes into your room, do not make a diagnosis of hypertension. Give him some time, rest him, do all the precautions that we mentioned. Maybe even call him back another day, ask him to measure it a couple of times at home. Make sure that, yes, this is a genuine blood pressure that requires to be treatment. Because you know very well that once you start the treatment, the patient is going to be on treatment for a very long period of time. And again, of course, we mentioned about sitting arrangement and quiet, etc. Next slide, please.
Thank you very much. We are getting something. So, one of the key message here is that there's nothing like, let me quickly measure your blood pressure. There's nothing like, let me quickly measure your blood pressure. Measure blood pressure should be deliberate and should take adequate time. So, can you just share with us ideally how blood pressure should be measured? We've looked at some of the things, but it's good to remind ourselves.
Next, please. Of course. So again, we are saying this again and again. The audience may be wondering why we are repeating this again and again. But I think, as Professor mentioned in his slides, and I'm again repeating it, it is very important. Monitoring of the blood pressure and the technique of monitoring is important. And why I say it again and again is that because doctors and nurses often do not do that, in spite of telling them again and again, blood pressure is not measured accurately. I know many of my residents, when I tell them, monitor, just check the patient's blood pressure, and I watch them and they do all the mistakes that we have said. And it's not that they're inexperienced, they're experienced resident doctors who know exactly all these points, but just do not want to implement the points. So I think implementation is important. Knowing is good, but implementation is important. We know that if we look at the do's and don'ts, make sure the patient doesn't fidget, doesn't cross legs, is not carried out to heavy exercise just before he comes, hasn't had caffeine or smoke just before he enters, is not taking medications because, for example, we've seen some patients who want to hide their blood pressure. Say, for example, pilots who come for check or some other job-related things where they often take antihypertensive treatment to come to you just to tell you that they don't have blood pressure. So make sure patients not consuming medicines or consuming other things which might push the blood pressure up again. Of course, morning measurements should be performed within 1 hour of walking after micturition. Evening measurements should be taken before bed. Those are the sort of best ways to do it, but that may not be possible unless the patient monitors the blood pressure at home. Again, resting and sitting on a table with your arm resting on the table, your cuff at the level of the heart. This is very important. Next slide, please. And this, of course, has already been showed by Dr. Familini, but I think it's again important. Keep this in your mind. I think if you can all look at this picture on the left-hand side, put it in your mind, and whenever you're measuring a blood pressure, just look at this picture in your mind. You'll see this patient leg peacefully on the ground, backrest which is good, cuff size which is proper, hand which is positioned proper. He's not talking. He's of course rested already. So please keep this picture in mind. So whenever you take a blood pressure of any patient, please do not rush in and take the blood pressure while the patient's standing or sitting without any bed rest, maybe at the corner of the bed. Maybe the patient is talking to his relatives. Maybe patient's agitated because maybe he's paid too high a fees, for example, and come to you, and maybe that's what agitating him, or he might have quarreled outside with somebody and come in. So I think it's very important. Keep this picture in your mind and take the blood pressure of the patient. Yes, in certain patients you might want to take lying, and certain patients you want to take standing to see for postural hypertension. That, of course, is an individual way of looking at blood pressure. But when you're doing a large volume of people just for checking blood pressure, sitting blood pressure is obviously the most ideal. Once you start the patient on treatment and patient has symptoms, you may want to do the blood pressure standing as well to look for posture. But this would be the consistent method at home. Again, you should tell the patient that when the patient does self-monitoring at home, the same technique has to be followed. So he has to follow all these protocols when he's monitoring at home also, because then only we'll get accurate recordings. Because if he comes back saying, I monitored my pressure at home, but it was very high, you have to ask him, when did you measure it? How often did you check? What had you done before that? Had you quarreled with anybody? So I think these questions are important. 5 minutes spent on taking a good blood pressure is very, very important before you start them on all sorts of triple, quadruple therapies. Next slide, please.
Thank you. So let's move to another aspect of our talk this afternoon, circadian rhythm in blood pressure. People believe that, oh, blood pressure should measure early in the morning. Get people who come to clinic and say that blood pressure has been, they say blood pressure has been monitored very early, and then my blood pressure is high or something is happening in the night. What is circadian rhythm in blood pressure measurement? Thank you.
Next slide, please. Now, Professor Fabellini has already mentioned, if you remember his earlier slide, he already mentioned about blood pressure, the nocturnal blood pressure. He spoke about dippers and non-dippers and the morning surge of blood pressure. So clearly the blood pressure doesn't remain same throughout the day and night. Now, we obviously know that we cannot measure night blood pressure because we are asleep. And that's why the importance of monitoring a 24-hour blood pressure through a BP machine or whatever system that you are using. Because it is, in my opinion, it's very important to know what is happening at night. And if you look at the British guidelines, they suggest that before you start treating a patient with hypertension, you should do at least one 24-hour BP monitoring so that you have a good idea of what is happening to the patient at night. It's very important because we know that BP begins to drop when you go to sleep, then it increases in the morning, and then again decreases during sleep at night. And disruption of the circadian rhythm can have a lot of problems. So people who have BP variability, people whose blood pressure doesn't go down at night, people who have surges of blood pressure just before they wake up, are associated with worsening of cardiac, stroke, and renal outcomes. So monitoring of the circadian rhythm, understanding the day-to-day variation is extremely important. Next slide, please.
All right, thank you very much. You've mentioned some of the issues associated with circadian rhythm. Again, like we know, it's a physiological thing. When the blood pressure goes down, there is compensation mechanism where the norepinephrines and the sympathetic hormones, and then the blood pressure comes up as we are waking up. But what are the clinical issues associated with this circadian rhythm? Can you please educate us, Dr. Dalla? Thank you.
Next slide, please. So sleep patterns may significantly affect the BP day and night profile. So it's clearly important. Some people have good sleep, some people have bad sleep. Some people who have disturbed sleep are going to have a different BP response. People with sleep disturbances and circadian misalignment by shifting of work. Please remember that a lot of people work at night. So then what would you say? Would you say that nocturnal, you can't talk of nocturnal dipping and non-dipping because that's going to happen during the daytime. And does the daytime blood pressure circadian be the same in somebody who sleeps at night compared to somebody who's working at night or not? So I think there are various issues that we need to look at. And of course, we know that this variation of blood pressure increases end organ damage. Next slide, please. Now, when you talk of blood pressure variability, there can be a variety of blood pressure variability. As you can see from the left-hand side, this is short-term variability, which is even beat to beat. So even blood pressure will vary beat to beat, but we are not worried about that, and we are not going to measure every beat blood pressure. Then, of course, you have to look at orthostatic, which is also BP variability, hypotension with standing up, which is also important. Then you have a diurnal variation, which we mentioned, morning surge, nocturnal dipping, non-dipping. Now, it's very important to look at this non-dippers and dippers, because normally the blood pressure should dip at night. And if it does not dip at night, then these people have more cardiovascular, stroke, and other problems. If, on the other hand, patients are extreme dippers, that means the blood pressure drops too low in the night, it's also very important because many times these people get up at night to go to the bathroom and fall down because the blood pressures are very low. And then you have people who have a morning surge of blood pressure. And we know that when they get this morning surge of blood pressure, there's a huge difference between the level at which the blood pressure has dipped and the morning surge of blood pressure, producing at that point myocardial infarctions and stroke. So those are the diurnal variation. Then, of course, you have day-to-day variation because we know that no blood pressure is going to be exactly the same one day and the second day. We also know that blood pressure is not going to be the same during visit to visit. And also we know seasonal variation. And this is very interesting because in where I stay in Mumbai, the weather is more or less same throughout the year. So we don't see BP fluctuations. But in North India, for example, there's a lot of seasonal variation, very cold weather, very hot weather, and blood pressure varies between the seasons. So they have to adjust their blood pressure measurement in people during the winters compared to summer. So I think it's important to remember that if you have very marked winters and summers, very cold and very hot, BP needs to be monitored. BP changes during the time, and you need to change your therapy accordingly. And then, of course, you have yearly change. So again, if you look at BP variability, it's a whole spectrum from a beat to beat to season, day to day, and year to year. And it's important for us to understand this when we are talking of blood pressure. So we know that when you want to check morning, evening blood pressure, you can do blood pressure measurement at home. That's easy. You can measure the blood pressure in the morning, afternoon, evening, or just before going to sleep. But for nocturnal blood pressure, you must have an ABPM to measure that. So that's very important. And again, of course, blood pressure will vary as one gets older. So that's the age variation as person gets older. Next slide, please. And we mentioned this thing about morning surge. So again, as you can see, patients sleeping on this diagram, as you can see, there is a BP which is at a very low level because there is a nocturnal dip. And then morning when the patient gets up, physical activity increases and patient is awake and there's a morning surge of BP. And you can see sometimes this morning surge may be very high. And this big surge of blood pressure variability can often lead to infarcts, which sometimes may be silent or otherwise. And you can see the morning surge versus the non-surge patients, you can see silent infarcts coming from 37% to 54%, and almost a 3 times incidence in stroke events between the ones who don't have the morning surge and those who have the morning surge. So whenever you treat blood pressure, please do a nocturnal blood pressure monitoring. Look for dippers versus non-dippers or extreme dippers, and look for the difference between the lowest level of blood pressure and the morning surge of blood pressure. Accordingly, you need to treat all these patients depending on whether you need to give blood pressure medicines at night or in the evening, because it makes a lot of difference to their cardiovascular events. Next slide.
Thank you, Dr. Dala. You mentioned some very interesting things, particularly about seasonal variations in blood pressure. There's a colleague of ours in Jos who is doing a lot of work and pushing these seasonal variations, and it's been difficult, but I'm excited about some of the issues that you have raised. So, in your opinion, what will you tell our listener? What is the best time to measure blood pressure?
Next slide, please. No, you missed a slide. Yeah. Now, again, of course, I would say that the best time is when you have time. So you must find time to monitor blood pressure. It should not be that you have only time just before you're going to work, so you rush and monitor your blood pressure. So first thing in the morning seems a good idea. You just woken up, you're peaceful, you haven't had any breakfast. Of course, you must have gone to the toilet, etc. So you're not with a full bladder, because you said that's an important thing. So that would be a good time to take your blood pressure. Other good time would be to take it in the evening. You come back from work, you rested. So don't come back from work and immediately take your blood pressure. Have a few words with your spouse, settle down a little bit, and maybe have your cup of tea. Don't eat anything too heavy at that time. Again, sit down peacefully for 5-10 minutes and monitor your blood pressure. And each time you take your blood pressure, you should monitor a couple of times. Now, we have these more sophisticated electronic machines which do automatically 3 blood pressure recordings. And then after the 3 recordings are taken, they exclude the first one and then do a mean of the next 2. So if you have that sort of a BP monitoring system, I think that's excellent. Number one, it measures your blood pressure, it waits for 30 seconds, takes the second blood pressure, waits for 30 seconds, and takes the third one. It excludes the first one, so that first agitation or the blood pressure which is higher in the first recording is taken out. You rest it for that 2-3 minutes, and then you have the second and third, and which is mean. So I think this gives you a very good measurement of blood pressure, especially if you are doing a home blood pressure and you're relying a lot on home blood pressure, which I think is very important. In my opinion, home blood pressure is very important. One is because you can take several readings. Obviously, you can't do that in a doctor's clinic. You may see a doctor once in 3 months, 6 months, but you need to monitor your blood pressure much more often. And secondly, and more importantly, it involves the patient in the treatment of the blood pressure. Once you involve a patient, then the patient will be much more watchful for blood pressure fluctuations, will be much more compliant with the medication, rather than simply seeing a doctor once in 6 months and then opening every morning, taking a tablet and not thinking of the blood pressure. So clearly involving the patient in any form of medical problem always leads to better results. And don't measure your blood pressure right after you wake up. So don't be immediately start measuring your blood pressure, get yourself all agitated. So, I mean, again, I think just use common sense. And this is just a rough idea of the common sense way of approach. Next slide, please.
I think one of the most important statements that will be taken away from this webinar is that don't measure your blood pressure immediately you wake up. That's what most of our people do. In fact, they measure the blood pressure on the bed. They've not gone to wee, they've not gone to empty their bladder. And they will phone you and say, oh, my blood pressure has gone to so, and so. Your blood pressure measurement should not be immediately you're waking up. There are some things you need to do. And don't forget that, like we've said, because it's circadian rhythm, you're likely not to get an accurate measurement. Thanks, Dr. Dala, for that emphasis. So, one of the things that has helped is ambulatory blood pressure monitoring or ambulatory blood pressure measurements versus home measurement. Can you just emphasize some of the roles of ABPM versus office or versus home measurement? Thank you.
Next slide, please. So, of course, office blood pressure is important. We all know that usually the diagnosis is going to be made by office blood pressure. But we know that there are 3 major problems of office blood pressure. One, as I mentioned before, you do not know what is happening at night. Number two, you have white coat hypertension where the BP is gone up in the patient's clinic, patient goes home and BP is absolutely normal. So that is white coat hypertension, which is also a problem. And the other, of course, is masked hypertension, where the blood pressure is normal in your clinic, but it is high outside. Now, how would you know it's high outside if the blood pressure is normal in the clinic? How do you pick up masked hypertension? You pick up masked hypertension if, for example, you measure the blood pressure and it is normal, but the ECG shows LVH. You've done an echocardiography and it shows LVH, or you got some proteinuria or some kidney function developing problems. You know that there's something happening, but the BP is normal at home. Such a patient must have an ABPM and monitoring at home or a home monitoring of BP. On the other hand, and of course, we must tell you that masked hypertension is as bad as real hypertension. So, masked hypertension is not benign. White coat hypertension is more benign, but usually people who have white coat hypertension often in the future start developing hypertension. So, it may be a sign that in the future you will get hypertension. But masked hypertension can produce organ damage and be missed because the BP is normal in the clinic. So, there, I think a monitoring at home or an ABPM is extremely crucial for these particular patients. Again, I already mentioned to you earlier, for nocturnal monitoring of blood pressure, there is no other option but to do an ABPM, because you can't, if you wake up at night and monitor your blood pressure, it's really not night blood pressure, it's awake blood pressure. So we must have a system where blood pressure is taken at night while the patient is asleep, which is not very easy, but we need to do that. Next slide, please. So we know the important points about that. Again, the problem with ABPM, what I find is that it is not really a good method of finding out, because most of our patients complain that when the BP is actually being measured, they feel discomfort. They often wake up at night. So really what happens is that two things happen. When you stick an ABPM on a patient, especially when he's doing it for the first time, they first of all find it very uncomfortable. So they don't want to do too many ABPMs. Secondly, they find that it is troublesome and affects their sleep. So the sleep pattern is disturbed when they have the AB put on. And thirdly, as the BP goes up and they get compression of the arm, they often wake up. So sometimes you wonder if the ABPM actually measures a real proper nocturnal blood pressure, or it is probably close to that, but not actually good, because as I said, the patient's a bit hyperactive, patient is anxious because the BP is being monitored, patient wakes up while the BP is monitoring. So those shortcomings need to be changed, and there are ways in which it is being changed. Next slide, please. So this is how we need to do. I mentioned about simple measurements to improve adherence by allowing the patient to monitor at home. But ABPM is not a pleasant test, and we need to have genuine BP monitoring. For example, we now have the BP monitoring watch. Now, BP monitoring watches are now getting more and more sophisticated. They were thought to be not very accurate, but we have seen some of the BP monitoring watches which are very good. I had the opportunity of testing one about a year ago. So I did a BP monitoring for about 2 days by myself. What I found with this BP monitoring machines is that, first of all, because it's a watch, it's very convenient, it's not painful, there is no cuff expansion, so it is proper. The difficulties I found was that when I exercised and did it, it was a bit variable, but it gave very beautiful nocturnal BP readings because it doesn't interfere with your sleep. You're not too anxious with it on your arm. It doesn't have any cuff making you up at night. And because you are sleeping, it gives very accurate measurements, unlike like when you are exercising. Then, of course, they're talking of various other things. For example, you can just hold a smartphone and it can measure your blood pressure depending on the flushing of your face. Now, that may be, again, progressing future, but that, of course, is not nocturnal. That is, of course, daytime, more simplification. And they were talking of other things like wearable patches, which might now also measure the pulse in your capillary circulation and be able to judge blood pressure at night. So I think we are moving in towards not using the regular ABPM cuff machine and moving towards more sophisticated. And I think it's important because we need more sophisticated nocturnal BP equipment. So I have no doubt that we need more of that. And I think more attention needs to be paid by the innovators and the people who make these machines. Next slide, please.
Thank you. As we begin to round up, there is no doubt that technology is improving. Unfortunately, many of these wearable blood pressure monitoring have not been standardized the way ABPM has been standardized. So you know what an ABPM home measurement means with an office measurement. But I think we'll get there. Like you said, people wake up even when the cuff is being inflated. So it's a waking blood pressure, really, not a sleeping blood pressure. But like we said at the introduction, even in the best settings, control is poor. Even in the best settings, not to talk of uh, places like sub-Saharan Africa, where there are many factors. In your opinion, what are the factors associated with poor control? We are talking about only about 20% control, even in the best settings. What do you think are these factors as well with this, and what can be done, even as we begin to round up this session?
Next slide, please. So, again, what are the causes of poor blood pressure control? One is poor adherence to drugs. So, that's an important factor to remember. If you don't take medicines, your BP is not going to control. Now, we can talk of what is the reason for poor adherence in the future slides. Then, of course, advanced stage. We all know that as age advance, people seem to care less about their health, or maybe they've got dementia, or maybe they've got physical disabilities so that they're not able to monitor their blood pressure. Then, of course, as you get increased PMI, your arm is increasing, your cuff size is not adequate. That produces a problem. Irregular physical exercise. So people sometimes have exercise and then blood pressure monitoring, maybe not picked up at times. Presence of menopause and other factors. So your patient-related factors, like as I mentioned, socioeconomic, age, income, education, housing, family support is very important. If you're an elderly man living alone, you're really not going to have a proper control of your blood pressure. Family support is important, if spouse important, and other unhealthy behaviors like tobacco, as you mentioned, physical inactivity, alcoholism, and of course other conditions which may be associated in particular. And I think Professor mentioned earlier, diabetes and dyslipidemia. In fact, we have termed a term called lipid tension, which is lipid high and blood pressure high, which is another very common. So look at lipid tension and diabetes as very important factors in relationship to poor control of blood pressure. Next slide, please. Now, if you look at the hurdles in terms of BP measurement, we have diagnostic hurdles, which is screening is not done. So it's important to screen everybody. The screening is done, but diagnosis is somehow still not made. Very low attendance and inaccurate blood pressure. We mentioned already about inaccurate blood pressure. So diagnosing blood pressure is very important. How will you control it if you don't diagnose it? Second is the treatment. You must have some sort of a protocol of how you will treat the patient. For example, it's important that we decide what drugs we'll use. It's important that we use only a single pill rather than multiple pills throughout the day. And it's important that we give combination therapy. We know from very well that combination therapy works very well. If you combine multiple drugs into a single pill, the adherence will be better. The multiple drugs will be in smaller dosage. Therefore, side effects will be less. And when multiple drugs are given together with different modes of action, then the BP response is much better. So as you know, ESC and ACC have always said that when you treat blood pressure, give one tablet a day as far as possible, combine drugs, 2 or 3 drugs, at least in that single pill. So single pill combination is the best way to have good adherence for the patient. Now there is, of course, drug shortages, which of course one must take care of. Therapeutic inertia is a very big problem. Therapeutic inertia on the field of the doctor and the patient. Many times the doctor also says, oh, blood pressure is okay. Patient says, no, it's okay at home. It's only high here. Somebody says, no, I'm old also. I don't want to take. All sorts of excuses that both the patient and the doctors make. And we call that as a therapeutic inertia, where the end result is that the BP is not controlled. So I think whether you are in private sector or public sector, where the patient flow may be too much, and you really don't have the time to explain to the patient the importance of blood pressure control is important. And again, once you started the patient on treatment, it is our responsibility to make sure the patient takes the treatment. Because sometimes what may happen, and particularly in the very younger group and the very elderly group, they will take the blood pressure medicines, but then after some time it starts dropping off. So you need to do reminders. You must use your cell phone to remind patients, have you taken your blood pressure? So maybe a weekly reminder, are you taking your blood pressures regularly? Maybe a system where they can monitor the number of pills that they're taking per week, so that if you put a pill box, they may realize, oh, on Wednesday, I forgot to take my BP medicine. So some way in which the patient can be reminded to take. So some recall system may be there. If, for example, you're purchasing medicines from a pharmacist, then okay, every month you purchase, say, 30 tablets. 30 tablets should get over at the end of the month. So if the end of the month you find there are 5 tablets still remaining, then you've missed 5 days of blood pressure treatment. So I think reminders, recall system, using pill boxes, making sure that medicines are affordable. There's no point in giving super efficient medicines and then the patient can't afford it because they're super efficient, but they're just not within the patient's pocket. So make sure that your medicines suit the patient's pocket, because otherwise patient won't take it. And provide them information, because if you want to avoid low adherence, you must empower the patient, inform the patient, make the patient understand all the issues. Next slide, please. So when you have this blood pressure, and how do you look at it? So when you have blood pressure which is almost in the normal range, you have to advise lifestyle is for everybody. So clearly we need to keep on emphasizing at every visit about the patient two things: lifestyle and about adherence. One of the best ways, there are nice papers on how to improve adherence. Now, I mentioned some of the ways: reminders, pill box, giving the patient the tablets, making the patient take the tablet in front of you. But probably the single and the most easy way to improve adherence is to tell the patient about importance of taking medicines and the importance of controlling BP at every single visit. So it's not just the first time that you need to do that. It's something like when when you talk with a child, you don't tell the child one thing and forget about it. The child's not going to remember. So every time you have to tell the child something and the child will then remember that. So similarly, every time the patient comes to you for your blood pressure control, you must tell the patient the importance of blood pressure control, the importance of adherence. And this must be done. If you do that again and again, the patient will adhere to the treatment. And of course, I've drawn this protocol just to show how important lifestyle is and how important adherence is. Of course, we all know that if you are in grade 2, grade 3 hypertension, you need immediate control of drugs. And of course, you must make sure, as per the guidelines, that the blood pressure must reach goal within 3 months. Next slide, please. And again, if you look at various guidelines, the various guidelines do differ. For example, American College of Cardiology suggests that you should start treatment when the blood pressure is more than 130. European Society of Guidelines suggests more than 140. India suggests again more than 140. But eventually, most of them agree that the goal should be 130 by 80. So that should be your goal. A couple of important things you should remember: that patients who have diabetes, heart failure, or at high CV risk must have much tighter control of blood pressure. Patients who have CKD and who are elderly or who have had thrombotic strokes, you should be a little careful and go slowly with their treatment. Sudden dropping of blood pressure to too lower levels in patients with CKD, elderly, or stroke may precipitate a stroke or may produce worsening of kidney failure. So in this group of patients, you have to be careful. If you look at the avoiding blood pressure, then again, CKD and elderly, be careful. And in almost all patients, try and avoid blood pressure becoming too low. So clearly watch out for too low blood pressure as well. So your aim should be to start everybody at least by 140, to go aim for 130, don't to go too low, to be more aggressive in diabetics and high CV risk patients, be a little bit more gentle in patients with CKD, elderly, and with thrombotic strokes. Next slide, please. And again, if you look at the the International Society of Hypertension 2020, they've divided into two groups: optimal and essential. So optimal is what you would like to have. So in a patient below 65 years, you want optimally to be the blood pressure should be 130 and below, and above 65, you want the blood pressure optimally to be 140. However, what is essential is that everybody's blood pressure should be 140 or below, and essential that blood pressure should come down by at least 20 millimeters from what the initial blood pressure was. And we should try and get this within 3 months. So that's important. Essential, everybody. Optimal, as many patients as you can. And of course, as soon as you can within 3 months. Next slide, please.
All right. Can you quickly tell us what can be done to improve control of blood pressure? Because we're trying to round up.
Next slide, please. I'll try and be fast. Now, effective use of blood pressure measurement, I think we mentioned that as well. To get the patient under control, important to measure blood pressure accurately, measure it as often as possible, treat the patient, educate the patient, and make sure that there is no inertia. And that's important both from the patient's point of view and the clinician's point of view. Next slide, please. And again, we mentioned about single pill combination. This is very important. There's a beautiful slide of ESC. Try as far as possible using a single pill. Try and use dual therapy in patients as the first choice. immediately move on to triple therapy, and then of course you may add a second pill if the patient is resistant to hypertension. So keep in mind always single pill, multiple combination therapy. Next slide, please. And again, prioritize your goals. So prioritize control nationally. So you have to look at nationality. So you have to look at the government looking after problems. You have to have community support so that the community helps the patient and the blood pressure control, and then individualizing optimal control. So blood pressure control is just not between the doctor and the patient, it's between the community and the patient, and between the government and the whole country nationally and the patient. Next slide, please. And again, one of the ways to avoid this problem is that there are few physicians compared to doctors. So we must shift the burden from the physicians. So nurses must take part in blood pressure control, community healthcare workers, even pharmacists, medical reps, paramedics. And many places, as you know, in USA, Canada, the pharmacist measures blood pressure. Pharmacies then adjust the blood pressure depending on the doctor's prescription. Next slide, please.
All right. Good. It's good to let our audience know some of the non-pharmacological ways to control blood pressure. We've talked about lifestyle. Okay, there's things about diet, about exercise. Can we just wrap up with this, please?
I think there's no doubt. Next slide, please. There's no doubt that non-pharmacological are very important. I'm sorry, the non-pharmacological two things. One is, of course, you have devices also which can reduce blood pressure and resistant hypertension. We won't go into details of that, but there are few people who are extremely resistant, and renal denervation, etc., may be a good thing. Next slide, please. So clearly, next slide, please. We can just this. I think is the last slide of mine. So there are many challenges which are still there and unmet. We've discussed that many times before. Look at side effects and make sure the patient has drugs which do not have side effects. Use a polypill, single pill. Use ABPM whenever required. Screen patients at the age of 18 years. Make sure they attain their goal. Telemedicine is a very good way to treat blood pressure. Make sure it is affordable. Make the patients aware of it. So I think this sort of completes the picture of how we can best make the patient diagnose the problem, treat the problem, and continue to take the problem so that the final control of the blood pressure, instead of being 20%, should at least be 70 or 80%. Thank you.
Thank you very much, Dr. Dalal. I think you've done giving us a very exciting afternoon. Thank you for mentioning so many of the guidelines. In fact, the Nigerian Hypertension Society also have brought out a guideline in 2020 that goes along the International Society of Hypertension. And I think we have been able to do justice to many of the issues that the 2023 Hypertension Day is trying to address. At this point, I think we'll just take a few questions, of course, of our time. Thank you very much.
Wow, such an amazing discussion. I really learn, and it is so enlightening that we got to know many crucial aspects about blood pressure measurement, how it can be accurately measured, and what is the role of morning blood pressure surge, and how it can be managed. So thank you, sir, for your wonderful discussion. Please allow me to take few questions. I know the time is running out, so I will just take very few questions which are very important and relevant for this topic. Please allow me, sir.
Please go ahead.
Okay. So my first question is, which one is better? Since we are talking about accurate blood pressure measurement, so which one is better, manual blood pressure measurement instrument or automatic blood pressure measurement instrument?
See,
Yes, sir.
Well, I will ask Dr. Dalal to answer that question because he has mentioned some of the things, the problems with mercury, which has been the standard, but the improvements now in electronic ones, which he mentioned, which he can just repeat. Dr. Dalal, please.
I think we all know that it's going to go the electronic way. I think mercury is now banned in so many countries, and we also don't use mercury anymore. So electronic ones are important. Now, the important thing about electronic ones, unlike the dial ones require calibration. The electronic ones cannot be calibrated. So once I asked somebody about what do you do, they said, if your electronic doesn't work, buy a new one. There's no way you can calibrate an electronic one. So if you find fault with your electronic, please buy another one. Today, they're not very expensive because there's so many companies making them. So I think that's the way. All the studies now are done on electronic machines. As I said, you can buy a cheaper version which measures your blood pressure once only. It's much cheaper. Or you can buy the more complex and costlier one, which measures 3 times and gives you an average of the three. So it doesn't matter what you use, but it's going to be electronic. The patient must learn to measure at home. So that's the important thing. So whatever the patient is comfortable with, the patient needs to be trained for it. And again, if it's an automatic, the patient doesn't have to learn anything. Simply know how to put the cup and the methods that we said about carefully how to measure blood pressure.
Right. Thank you, sir. Moving on to another question. What
Yes.
will be the best therapy for managing the early morning blood pressure surge? Yes.
Well, he mentioned it and I mentioned it earlier on, but we need drugs, particularly that will give you a longer life that work for 24 hours. And studies have shown that for early morning surgeries, the best drugs are the RAS blockers, either the AC inhibitors or the ARBs. Telmisartan particularly has said to be the best Satan in the market now. For blacks, ISH is still recommending calcium channel blockers with or without diuretics. I'm going to use diuretics. You use the thiazide-like diuretics rather than the thiazide diuretics. But when you're talking about really going to work with dippers and non-dippers, particularly you have to think about the RAS blockers.
Thank you, sir.
I
Dr.
think
Dalal, sir, your please.
Professor made a very important point. When you're using blood pressure medicines, and especially when you're using a single pill with a combination, make sure your blood pressure medicines act for 24 hours. Because when are you going to get the surge? You are going to get it in the morning. So you've taken a blood pressure in the morning, you're talking about almost 24 hours later that the blood pressure will surge. So you want to make sure that the treatment you are taking is actually effective in the night, at the time of the surge. Many people suggest that you should take doses in the evening before morning. There are a lot of studies. Some are positive, some are not positive as to whether you should take your blood pressure medicines in the evening or in the morning. Now, I feel that if your blood pressure surge is very high, and in spite of taking a combination medicine in the morning, your BP is not controlled, then it may be a good idea to take, as Professor said, a RAS blocker somewhere in the evening to control in patients, especially who are super surging in the evening, in the night, in the morning, and whose blood pressure cannot be controlled with a single drug in the morning. So maybe a RAS blocker in the evening. But I think you can adjust the medicines, but the number one important thing is that the drug should be 24-hour acting, and really 24-hour, not dropping off after 20 hours.
Right. Thank you, sir.
In which case, telmisartan and ARBs are excellent drugs for 24-hour control.
Right. There is one more question specifically addressing to Professor Familoni, sir. The question is why there is a rise in the hypertension prevalence in Nigeria?
Well, it's obvious the factors have been reasonably well defined. I've mentioned about rural-urban migration. Everybody is moving into the city centers, and with the problem, there is congestion, there is stress on the roads, there is stress on the essential things, and then diet. Okay. Unfortunately, the Western world is going away from the refined food and all these high cholesterol diets. But because of urbanization and modernization, that is what we're now taking. People are taking very high salt diet. And we know that the black man's kidneys cannot handle salt. Our arteries are very reactive to salt. And many of the things that we take in the fast foods is now classed to eat at the fast foods, not at the bookers or even in your house. And these are places where you have very high salt diet, very high cholesterol. Smoking is increasing, particularly among the low and the middle income people. People who cannot even afford to eat, they go and buy cigarettes, and this causes endothelial dysfunction and things. Obesity is increasing. It has been an epidemic in the Western world, and it's getting to be a problem. School children are now, but we're looking at studies that shows about 20% of school children in some of the elite schools are already obese, okay? And these are parts of the problems. Exercise, sedentary living. You get to your car, you get into the car, get an elevator to your office, you are in the office at 5 p.m., get to your home, go and drink beer and all those things. And so these are the issues. And unless the community and the government does something really fast, we're going to get into an explosion of hypertension and cardiovascular diseases.
The only extra point I would like to make is stress, mental stress, which is why we constantly talk about meditation and yoga and whatever, because I think people are so stressed about today about everything and anything. And of course, the world is very stressful. So I think meditation can also play an important role in calming down and bringing the blood pressure. So I always put meditation as one of the non-pharmacological meditative ways of treating blood pressure.
Right.
A lot of studies have shown that meditation, yoga, and all those things can actually drop blood pressure significantly. I agree with you.
Right. So I will just take a last question now. So what is the significance of taking blood pressure on right arm? Usually it is taken on left arm. So why right arm blood pressure measurement is important?
For those of us who run clinics, it's interesting when you want to take the blood pressure. Patients believe that blood pressure should be taken on the left arm because they say it's nearer to the heart. In fact, when you want to take their blood pressure on the right arm, some say, doc, you should take it on the left arm. But like Dr. Dallas said, the truth of the matter is that blood pressure should be taken on both arms, particularly if you are seeing the patient initially, and then you choose the higher figure. But medical school, we know that the way things are, you should be on the right side of the patient. And when I tell students that's why you're on the right side of the patient and you should take the blood pressure on the right. But ideally, in practice, take both arms and choose the higher figure. But our people are fixated that the pressure should be taken on the left arm because the heart is on the left. The heart is not on the left, really. It's behind the sternum.
I think Professor Family, you brought out a good point which we hadn't discussed so much. But many patients ask, should you measure left arm or right arm? And as Professor said, you must measure at least once in both arms, because some people have a difference between two arms. And we know that if there is a marked difference between two arms, you may be talking about some sort of a aortoarthritis or some other reason which may also produce hypertension. So very severe difference between the two arms requires further investigation. But if the difference is not very severe, then as he mentioned, measure always in the arm which is bigger, which is higher, and then always use that arm. So don't once here, then that gets confusing. Just choose an arm whichever you want once you found that there is no difference between two arms, and then continue on that arm.
Right. Thank you, sir. Actually, we have received a lot of questions and time may not permit to take all those questions. So I will restrict this question answer session here. So I would like to thank both of you, sir, for taking time from your busy schedule. It was really a very fantastic session. I'm sure our audience have enjoyed it. I would also like to thank our technical partner, Dr. who has facilitated this session, and all our accrediting bodies who has given CME and CPD points for this. I would like to also inform our audience there is a small quiz once we end this webinar. Please attend that quiz, and if you qualify for that, you will get the certificate mail on your registered mail ID. So please attend the quiz and download your certificate. Thank you. So thank you, everyone. Thank you, sir, and thank you to our lovely audience.